Good morning. My name is Jagriti Bhardwaj. I'm second year med student. I'll be doing your eye and ear examination. Do I have your consent?
Yes, please.
Thank
Go ahead.
Eye examination. Number 1, visual acuity. To test the acuity of central vision, use a Snellen eye chart. Position the patient 20 feet from the chart. Patients who wear glasses other than for reading should put them on. Ask the patient to cover one eye with a card to prevent looking through the fingers and to read the smallest line of the print possible. Attempting the next line may improve performance. A patient who cannot read the largest letter should be positioned closer to the chart. Note the intervening distance. Identify the smallest line of print where the patient can identify more than half the letters. Record the visual acuity. Visual acuity is expressed as two numbers. The first indicates the distance of the patient from the chart, and the second the distance at which a normal eye can read the line of letters. Second, visual field static wiggle test. Position yourself about an arm's length away from the patient. Close one eye and have the patient cover the opposite eye while staring at your open eye. Place your hands about 2 feet apart out of the patient's view, roughly lateral to the patient's ears. Wiggle your fingers and slowly bring your moving fingers forward into the patient's center of view. Ask the patient to tell you as soon as he or she sees your finger movement. Test each quadrant. Test each eye individually and record the extent of visits in each area. Note any abnormal field cuts. Conjunctiva and sclera. Ask the patient to look up as you depress both lower lids with your thumbs, exposing the sclera and conjunctiva. Inspect the sclera and palpebral conjunctiva for color. Note the vascular pattern against the white scleral background. Look for any nodules, swelling, or redness. Pupils. Number 1, size. In a dim light, inspect the size, shape, and symmetry of both the pupils. Measure the pupils with a card showing black circles of varying sizes. Note if the pupils are large, more than 5 mm, or small, less than 3 mm, or unequal. Light reaction. In dim light, test the pupillary reaction to light. Ask the patient to look into distance and shine a bright light obliquely into each pupil turn-wise turn. Both the distant gaze and the oblique lighting help to prevent a near reaction. Look for two things. 1, the direct reaction, which is the pupillary constriction in the same eye. Second, the consensual reaction, which is the pupillary constriction in the opposite eye. Next, near reaction. If the reaction to light is impaired, test the near reaction in both dim and normal light. Testing one eye at a time makes it easier to concentrate on the pupillary responses. Hold your pencil at about 10 centimeters from the patient's eye. Ask the patient to look alternately at it and into the distance directly behind it. Watch for pupillary constriction with near effort and convergence of the eyes. Extraocular movement. Ask the patient to follow your finger or pencil as you sweep through the 6 cardinal directions of gaze. Making a wide H in the air, lead the patient's gaze. Number 1 to the patient's extreme right, then to the right and upward, and down to the right. Then without pausing in the middle, to the extreme left, to the left and upward, and down on the left. Pause during upward and lateral gaze to detect nystagmus. Move your finger or pencil at comfortable distance from the patient. Convergence. Ask the patient to follow your finger or pencil as you move it in toward the bridge of the nose. The converging eyes normally follow the object to within 5 cm to 8 cm of the nose. Ophthalmoscopy. Due to unavailability in the pandemic, I am using the phone to demonstrate. Using your fundoscope, locate the optic disc, bring it into sharp focus, and then examine it. Note for any sharpness, clarity, color, and size of the disc. Usually it is yellowish orange to creamy pink. Then inspect the retina, including arteries and veins as they extend to the periphery, arteriovenous crossings, the fovea, and the macula. Identify any lesions of the surrounding retina and note their size, shape, color, as well as distribution. Ear examination. Number 1, inspecting the auricle. Inspect the auricle and surrounding tissue for deformities, lumps, or skin lesions. If ear pain, discharge, or inflammation is present, move up the auricle up and down, press the tragus, and press firmly just behind the ear. Number 2, otoscopy. Due to unavailability, I am using a scale to demonstrate. To see the ear canal and drum, use an otoscope with the largest ear speculum that inserts easily into the canal. Inspect the ear canal, noting any discharge, foreign bodies, redness of the skin, or swelling. Inspect the ear drum, noting its color and contour. The cone of light, which is usually easy to see, helps to orient you. Then auditory test. Weber test. Number 1 is whispered test. Stand 2 feet behind the seated patient so that the patient cannot read your lips. Occlude the non-testing ear with the finger and gently rub the tragus in a circular motion to prevent transfer of sound to the non-testing ear. Exhale a full deep breath before whispering to ensure a quiet and sound voice. Whisper a combination of 3 numbers and letters such as 4, X, 1. Use a different letter number combination for the other ear. Interpretation: the normal patient will repeat initial sequence correctly, or the patient responds incorrectly, so test a second time with the different letter number combination. Abnormal: 4 of the 6 possible letters and numbers are incorrect. Conduct further by audiometry testing. Number 1, Weber test. Place the base of the lightly vibrating tuning fork firmly on top of the patient's head or on the mid of the forehead. Ask whether the patient hears the sound on one side or on both sides. Normally the vibration is heard in the midline or equally in both ears. If nothing is heard, try again, pressing the fork more firmly on the head. In unilateral sensory hearing loss, sound is heard in the good ear. Remember, sensory neural hearing loss, which is unilateral, sound is heard in the good ear. Renee test. Compare air conduction with the bone conduction. Place the base of a lightly vibrating tuning fork on the mastoid bone behind the ear and level with the canal. When the patient can no longer hear the sound, quickly place the fork close to the ear canal and ask if the patient hears a vibration. Here the U of the fork should face forward, which maximizes the sound transmission for the patient. Normally the sound is heard longer through the air conduction than through the bone conduction. In conductive hearing loss, sound is heard through bone longer than through air. However, in sensory neural hearing loss, sound is heard longer through the air. Thank you.